Okay. So, good evening, everyone, and welcome to the Xpert webinar. I welcome you all on the behalf of Juventus Gromax. I'm Harshada Savan, and our state head, Mr. Jaipal, is here with us. Regarding today's topic, it is known that exocrine pancreatic insufficiency and diabetes may coexist, and despite of its high prevalence, very little is known about the clinical consequences and its management. So our today's topic for the discussion is challenges in the management of coexisting EPI and diabetes. So I take pleasure to introduce our eminent speaker, Dr. Mohsin Aslam, to address this topic. Dr. Mohsin Aslam is a consultant physician and clinical researcher at Asian Institute of Gastroenterology, Hyderabad. To moderate the session, we have Dr. Manohar Reddy with us, and he is a renowned gastroenterologist in Hyderabad, and he is currently practicing in Asian Institute of Gastroenterology. So I request Dr. Manohar Reddy to introduce Dr. Mohsin Aslam.
Yeah, good evening and thanks, Juventus, for this opportunity. Today we'll be discussing an interesting topic, which is quite common for us since we work in a tertiary care center. We see a lot of chronic pancreatitis cases who present with exocrine insufficiency and at the same time diabetes mellitus, which becomes challenging to manage both. And today we have Dr. Mohsin Aslam with us to discuss in brief regarding this management of exocrine pancreatic insufficiency, which many times coexists with diabetes. And he'll go ahead with this topic. And after this topic, if we have any questions, we'll be able to take those questions. Over to Mohsin.
Yeah, thank you, sir. And thank you, Juventus, for giving us this opportunity. So straight away moving to the topic, challenges in the management of exocrine pancreatic insufficiency coexisting with diabetes. So there are two entities. One is pancreatogenic diabetes, that is diabetes occurring in patients with chronic pancreatitis. That is a well-known fact. And it is known patients who are having pancreatitis, they are regularly screened for development of diabetes and they are managed. So first, they are being managed for exocrine insufficiency because it's a known fact. And on top of it, we may go for management of diabetes. And the diabetes in these situations is very difficult to manage because it's often a brittle diabetes. Because here in this patient, there is absence of both glucagon and insulin. So they have a very brittle nature. The moment we give insulin, patient goes into hypoglycemia because of the increase in peripheral insulin sensitivity and also decreased glucagon. And if you reduce the dose of insulin or hold the insulin, then the sugar levels shoot up. So it's a very roller coaster ride. But now today I am going to discuss is development of pancreatic exocrine insufficiency in patients with type 1 and type 2 diabetes. That is we hardly suspect any development of exocrine insufficiency in patients with diabetes. Usually they are all present with the symptoms of GI, and we label them as gastroparesis or diabetic irritable bowel syndrome, or maybe some side effects of some medicines. But we fail to recognize the development exocrine insufficiency in patients with diabetes. So now coming to the topic, pancreas is a double entity organ with both exocrine and endocrine component reciprocally interacting and closely cooperating for the digestion, absorption, and metabolism of oral nutrients. So hence, it is not surprising that the disorders of the exocrine pancreas also affect the endocrine system. That is again well known, and vice versa. That is the endocrine system, that is patient is already having diabetes and may develop exocrine insufficiency. It is a known fact that patients with chronic pancreatitis develop diabetes, that is type 3C diabetes, caused by destruction and fibrotic injury to the islet cells, and very difficult to manage. However, very little is known on the influence of diabetes on the pancreatic exocrine function. So the major portion of the digestion is taken care by major pancreatic enzymes like lipases, amylase, and proteases. So any reduced secretion of these enzymes from the pancreas, rapid destruction, or inadequate contact between the food and the pancreatic enzymes within the intestine results in the nutrient maldigestion, and this is known as pancreatic exocrine insufficiency. So what are the causes? Again, pancreatic causes, that is chronic pancreatitis, acute pancreatitis, or pancreatitis of any other etiology. Non-pancreatic causes, again, diabetes mellitus is most common, followed by celiac disease or Crohn's disease, Zollinger-Ellison syndrome, and any GI or pancreatic surgery where there is decreased exposure to the food substance to these enzymes. So, the major clinical consequence of pancreatic exocrine insufficiency is fat maldigestion and malabsorption, which results in steatorrhea, that is frothy, foul-smelling, and buoyant stools. They present with non-specific symptoms, that is abdominal pain, flatulence, altered bowel movements, weight loss in adults, or lack of weight gain in type 1 diabetes children. So these are often confused with the symptoms of long-standing diabetes, that is gastroparesis, or maybe irritable bowel syndrome. And most of the patients are on metformin and alpha glucosidase inhibitors, so they may be confused with also the side effects of these medicines. So coming to prevalence, pancreatic exocrine insufficiency is quite common in diabetes, but hardly diagnosed. So cross-sectional studies have shown that prevalence of pancreatic exocrine insufficiency to be ranging from 25 to 74% in type 1 diabetes and 28 to 54% in type 2 diabetes. There are different studies. And one of the cross-sectional study from India, which recruited 89 type 1 diabetic patients and 95 type 2 diabetes patients, the prevalence of PI in diabetes was around average 30%. So now, what is the pathophysiology? So exact pathophysiological mechanisms for the development of PI in diabetes is not known. There are proposed hypotheses. One is insulin has a trophic action on the pancreatic acinar tissue. So in patients with long-standing diabetes where there is insulin deficiency, or type 1 diabetes where there is absolute insulin deficiency, there is a loss of this trophic action, which results in the loss of acinar tissue and loss of exocrine function. Other proposed hypothesis is microvascular complication of diabetes resulting in microangiopathy, tissue ischemia, and tissue fibrosis of exocrine pancreas, resulting in loss of exocrine function. Again, coming to autonomic neuropathy in long-standing diabetes, which results in loss of neurohormonal signal and loss of enteropancreatic reflexes, results in loss of exocrine function. Again, one hypothesis is like post-inflammation, post-viral infection, like we have seen in COVID now, where post-COVID many people have developed diabetes, or post-pancreatitis, where the entire gland is affected, where both exocrine and endocrine functions are affected simultaneously. So risk factors: patients who have early onset of diabetes with longer duration of diabetes, presenting at elderly age where there is already loss of exocrine function, and poor glycemic control. So diagnosis of exocrine functions in diabetes, it is often difficult to detect PI in patients with diabetes. Symptomatic in the early stages of exocrine insufficiency. The classical symptoms of steatorrhea and weight loss develop only when there is severe pancreatic exocrine insufficiency. So there should be very high suspicions of PI in patients with diabetic. So these patients more commonly present with altered bowel movements, abdominal discomfort, and flatulence. Diabetic patient often complain symptoms of fatigue and difficulty in controlling blood glucose levels. Again, because difficulty in blood glucose levels is because of maldigestion. Maldigestion of nutrients results in decreased nutrition delivered to the distal ileum. So decreased secretion of GIP and GLP-1 from the gut, decreased stimulation of pancreatic beta cells, and decreased insulin secretion, and poor glycemic control. So although there are many causes of diarrhea in diabetic patients, particularly small intestinal bacterial overgrowth and diabetic dysautonomia, PEI should be suspected in patients with long-standing type 1 and type 2 diabetes. It should be considered after excluding the other causes like celiac disease and side effects of other uh, drugs like metformin and alpha glucosidase inhibitors before considering the diagnosis of PEI. Now, coming to the test to diagnose PI, there are many direct function tests and indirect function tests. The most important one is 72-hour fecal fat estimation, which is a gold standard, but it is not routinely done. It is done only in the clinical research setting because it is very cumbersome to do. Other tests like cholecystokinin and secretin stimulation tests, again they are gold standard, but they are invasive and complicated and done only under research test settings. Now, coming to indirect function test, fecal chymotrypsin activity, again it is good for compliance control done with a single stool sample, but for this PERT should be discontinued before performing this test, and it has very low sensitivity. Fecal elastase 1 concentration, this is most commonly performed, and it can be done even on the patients taking enzyme replacement therapy. Again, requires single stool sample, and it is commonly done nowadays in India. C13 mixed triglyceride bed test, again, it is far superior than fecal elastase 1, but it's not being done in India. So coming to fecal elastase 1 assay, it is currently the most commonly used test to detect PI in patients with pancreatitis and also long-standing diabetes. A value of more than 200 microgram per gram of stool are within normal limits, whereas values of less than 100 indicate significant exocrine insufficiency. So, several studies have shown that 1 in 3 patients with diabetes had impaired exocrine function when they measure the fecal elastase 1 levels. So that means if you are not measuring, then we are losing around 33% of the patients with exocrine insufficiency. And steatorrhea can be detected in 60% of patients with diabetes and reduced fecal elastase 1. So that means another 40% we are missing because they don't have any symptoms. So if we do not perform the test, we are going to miss out on nearly 30 to 40% of the patients with exocrine insufficiency in patients with diabetes. And this test is now commonly done in laboratories across India. Advantage is that it is non-invasive and stable and unaffected by exogenous pancreatic enzyme substitution. Patients need to stop taking pancreatic enzymes before conducting that, and this should be avoided in patients having dietary diseases. Coming to 13C mixed triglyceride bed test, most recent test, fairly accurate. It could be used to monitor the effect of enzyme therapy on fat digestion. It is simpler than the standard fecal fat test, but not available in India. So now coming to management part, the mainstay of treatment of management of PI in diabetes is enzyme replacement therapy. There is hardly any data or guidelines on the what is the dose, duration, frequency of PERT to be given in diabetes. So treatment we usually follow is what is given in the literature for the management of chronic pancreatitis. So these are the various preparations approved worldwide. So the lowest recommended dose for enzyme replacement therapy in patients who are enzyme deficient is 25 to 40,000 units of lipase per ml, and then titrated upwards according to clinical response. Maximum recommended dose of PERT in adults is 75,000 to 80,000 units of lipase with each meals. Optimal action could be achieved by taking the preparation along with the food or immediately after the food. So enzyme replacement therapy has an impact on glucose metabolism. In patients with diabetic exocrine insufficiency, it has been seen that there has been reduced insulin requirement and contribute to improved control of glucose metabolism in patients who are on enzyme replacement therapy. As I've already discussed earlier, that patients with uh, exocrine insufficiency have poor control of glycemic because of decreased GIP and GLP-1 secretion. So once you start replacing this enzyme therapy, the more nutrient delivery to the distal ileum, more secretion of GIP and GLP-1, and better control of diabetes. Study with very high number of patients with diabetes on enzyme replacement therapy had shown that the patients with reduced elastase levels when given enzyme replacement therapy, their HbA1c levels lowered, and also the the requirement of medicines also had reduced. So, yes, what we have discussed earlier, impaired GLP-1 secretion can be normalized by enzyme replacement therapy, resulting in better glycemic control. So, apart from helping in controlling the symptoms of steatorrhea, it also helps in preventing the qualitative malnutrition and metabolic complications. And adequate enzyme replacement therapy is very important in the management of diabetes. So, once the malnutrition part is controlled, so patients having B12 deficiencies and again neuropathy symptoms also subside. And there are studies which have shown that vitamin D levels, if they are low, they result in poor glycemic control. And as it is a fat soluble vitamin, so Supplementing vitamin D along with these enzymes helps in better absorption of vitamin D and better glycemic control. So, for optimal digestive action, a pancreatic enzyme preparation should survive the gastric acid milieu. It should be get released into the duodenum along with chyme and contain the correct dose of lipase. Because lipase is the most vulnerable and its survival is as low as 1% of the enzymes in the absence of fat in the diet. So, high concentration of lipase in the pancreatic enzyme supplement results in achievement of the optimal dose, and the pancreas has a huge resource of enzymes, but only 10% of daily lipase output, that is, which is 6 lakh units, is required for fat digestion. Means 6 lakhs means nearly 6,000 units, 60,000 units. So daily dose of at least 20,000 per meal of lipase is required for fat digestion. So initial response to enzyme replacement would be erratic in patients with PI. So supplementation should be started with a higher dose of lipase with each major meal, and once the patient stabilizes, we can reduce the dose based on the response to the treatment. So size of the patient's weight, meals portion, and nutritional status determine the starting and maintenance dose of the pod. Coming to side effects, it is well tolerated with few side effects. So it is a supplemental enzymes and which acts within the lumen of the intestine, and it is considered as an intraluminal treatment and not a systemic therapy because it doesn't get absorbed in the blood. Most common side effects include mild abdominal pain, nausea, vomiting, or constipation. To summarize, patients with diabetes have an increased risk of developing enzyme insufficiency due to pancreatic acid atrophy. Symptoms of PI do not manifest until the duodenal lipase levels fall below 5 to 10% of normal postprandial levels. Clinical consequence of PI is fat maldigestion resulting in steatorrhea and weight loss. Upon clinical suspicion, and pancreatic function test should be performed for identifying clinical enzyme insufficiency, and the enzyme replacement therapy is the main pharmacological treatment for PI. So it is effective when given with meal rather than pre or post meal. Thank you. So if any questions we can take.
Yes. So I request all the audience to post your questions in the chat box so we can take those questions.
Is the chat box? We are not able to see the chat box.
You can read out questions then.
Yes, chat box is there, but
No
not.
questions.
Yeah, yeah.
Any
Question is
questions,
not.
you can read them out.
If any questions from your side, even you people can ask us any questions.
Or if they are connected, they can also speak directly with me.
Yeah, the facility is not available to speak, but they
Okay.
can put the questions. Okay, there is one question is here. Uh, is there any dose difference for type 1 and type 2 diabetes mellitus patients?
No, there is no dose difference in type 1 and type 2. Again, it depends on the nutritional status, as I mentioned, weight of the patient, and what do you call weight of the patient and the size of the meal what the patient is taking. If the patient is taking very high meal, rich in fat, then you can give higher doses. Otherwise, you can give on the lower doses. Dose required usually we recommend because pancreatitis patients they usually require very high dose of 24, 25,000, 40,000. But our diabetic patients we can manage with 10,000 units of lipase with each meal. Because again, if you give very high doses, the cost is an issue. Then they may become non-compliant to our diabetic medications. So that also we have to take into account.
And especially in Indian patients, since fat intake is not really high, so we can start off with low doses and slowly titrate according to their symptoms.
So, for any practitioner in their office practice, which are those symptoms or indications that he should go for, like to identify there is a diabetes and EPI coexistence, and they can start with the pancreatin therapy.
See, one thing is patients having GI symptoms, again, they may be confused with irritable bowel syndrome and side effects of the medicines. So, if the facilities for testing fecal elasticity is not available, what they can do is try first stopping the medication for metformin and all. Even after that, if the patients are not resolving or just if not responding to standard treatment of mm, antispasmodics and PPI, then you can just add small doses of enzyme replacement therapy and look for the response. But best thing is to get a fecal elastase level because it will give the degree of insufficiency. If it is severe, then we need to give the supplement with the very higher doses of replacement therapy.
And before that, we should look into causes for other causes for uh, maldigestion, like small bowel causes, should be ruled out. A thorough investigation should
Yeah,
be done,
first GI causes should be ruled out before labeling as a PA.
If
especially small bowel causes like small bowel pathologies and small intestinal bacterial overgrowth. These all should be ruled out.
Okay, and after that, first of all, the fecal elastic taste is important.
This is not very widely available and it's an expensive test. So before that, we should make sure that there is no pathology in the small intestine. Then, if possible, as Dr. Mohsin mentioned, it's better to do it as an index than start before starting PEI. But
Okay, we have got one more question, that is, what is the cost of fecal elastase test? If
Outside, I don't know what it is costing. We do it for 2,500 here.
okay, so in AIG the cost is 2,500, right?
And we give
One
exact it's a quantitative, not the qualitative. Outside some labs, we have seen they are doing only qualitative, not the quantitative, and they're charging around 5,000 rupees for that.
one more question, sir. If patient is taking insulin, then after the uh, pancreatin maintenance with pancreatin, is there any change you have seen in your
Yeah, insulin
practice?
requirement comes down. Insulin requirement comes down, and also if the patient in alpha glucosidase inhibitors, because these medicines have to be taken along with the food, and even this enzyme replacement therapy has to be taken along with the food. So better to stop alpha glucosidase inhibitors and change it to some other drug.
So we can summarize that if patients of diabetes mellitus are having the symptoms like malabsorption and the abdominal pain or weight loss or bloating, they are constantly complaining about these symptoms.
And poor
Then
glycemic control also.
yes, and poor glycemic control. Then it can be ruled out that EPI
You
is
have to
the
rule
cause.
out. You have to perform test and rule out. Huh?
Yes. So there is no more question. So first of all, I would like to thank you both for your efforts to make this topic as simple as possible and make everyone to understand. So thanks a lot for that, sir. And I would like to call Mr. Jaipal Reddy to say a few words as a vote of thanks. So, Mr. Jaipal, over to you.
Yeah. Thank you, sir. First of all, thank you very much for the time, valuable time. And thank you, Mohsin sir and Manohar Reddy sir, for your very informative and scientific deliberation. Make it very simple to understand, even very layman language kind. So thank you, sir. Thank you very much.
Thank you.
Thank you, Jaypal Reddy.
Yeah.
Thank
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 you.
you so
Thank
much.
you. Good night.
Good night. Good night to all. Thank you.
तू नीचे से बता रही है।